Great. Again, thanks everyone for joining. For those of you who missed last week's lecture, please, I think the recording is probably out by now, but at any rate, if it's not, when it does come out, if you're interested in going back and taking a look at that, please feel free. And just to recap a little bit, last week we talked in a very kind of broad way about epidemic or pandemic preparedness and response, and what are some of the important elements of that. And I covered, these were the take-home points from that lecture. If you recall, those of you who heard that the zoonotic interface is really, and viruses that come from the zoonotic interface, that is between humans and animals, is really the biggest threat for us. The response, and we'll talk more about this today, of course, what's most important is really developing the capacity to respond in country in really at that interface. And so coming in from other places, flying in and flying out and providing technical expertise, it's not that it doesn't have utility, it is an important element of it, but really it's developing the capacity in the trenches, if you will, that is the most important. We are making some progress in different types of diagnostics, and so increasingly figuring out what pathogen causes an outbreak or a pandemic is not our biggest challenge. Often our biggest challenge is once we identify it, which we can do relatively rapidly, then trying to control, of course, and learn more, especially about new pathogens. And then, as I mentioned last week, regardless of what your sort of general philosophy is, whether you say you're primarily concerned about infections and outbreaks in Europe or the UK or London or Kyoto or New York or wherever it may be in the world, increasing that capacity is in the best interest of everyone, because of course we're all seeing, in the COVID-19 outbreak is the obvious representation or example of that it's all connected. And so we can't say it's not really our problem what happens in one area of the world, or why should we have to worry about what happens in Africa or Asia or North America. Really, we're all connected and we're seeing that. So this really needs to be a global approach and a global strategy for outbreak control. And then recognizing that it's not all about just biomedical innovation and epidemiology. Those are incredibly important in this whole process. But we have to recognize that most outbreaks are disproportionately affecting the poorest populations in the world. That's certainly true when we have outbreaks such as Ebola that are relatively restricted to areas of sub-Saharan Africa. But it's even true if we look at the COVID-19 outbreak or pandemic, that although certainly spread throughout the world, if we look at the mortality and morbidity to that, it's still, again, disproportionately affecting the poorest populations of our planet. And so we need to recognize that it's not only about the biomedical part, but it's also about being proactive as an advocate for health as a human right, and the social, and recognizing the social and political determinants that are also extremely important, and trying to correct those. So that's a brief recap of what we discussed last week. And then today, I'll try to cover, in a very broad sense, what do we do? How do we make our systems for outbreak control and preparedness more efficient? So first of all, just a very general principle, and I get asked this many times by different sources, what's something that I've learned over the years, and I now reminds me, I've forgotten, Ayako, to give a little bit of introduction of myself, but so maybe I'll stop briefly about that. I'm a physician by training in internal medicine, infectious diseases, the master's degree in public health and tropical medicine. As you may be able to tell from my accent, although I work in the UK, I'm originally from the United States, have worked in many different places in the world, got into this business of outbreak response, especially in the field of viral hemorrhagic fevers like Ebola and Marburg and Lassa and those sorts of viruses, initially working with the US Centers for Disease Control and Prevention, and then worked in various settings over the years in academia at Tulane School of Public Health and Tropical Medicine in New Orleans. I was at 4 years in Peru, a couple years in El Salvador, some time in Geneva at WHO, and then for the last 4 years or so, I've been privileged to lead, and what I'll talk more about today, something called the UK Public Health Rapid Support Team, which is co-led by the London School of Hygiene and Tropical Medicine and Public Health England. So that's an academic and government collaboration. And I'll tell you more about that in just a minute. So that's my background. And so moving on now, what do we do? How do we try to combat these situations? Certainly global situations or pandemics like COVID-19, but also increasingly we're seeing that more regional outbreaks still have global impact. And so certainly the recent, over the last 2 years, outbreak of Ebola in Eastern Democratic Republic of the Congo, and definitely the earlier outbreak of Ebola in the western part of Africa, in Guinea and Sierra Leone and Liberia. These were primarily local and regional problems, but nevertheless had a global impact in terms of imported cases and disrupting travel and trade, and panic and diverting our attention and resources. So these are really becoming increasingly frequent, and so we need to really figure out how to deal with these, not only on a global scale, but on a local scale. And an important thing, coming back to my original point for this slide, people ask me, what's the most important? What have you learned over the years? And one of the things that I have learned in a lot of different outbreaks is that ultimately effective control for outbreaks is a local phenomenon. That does not mean that it does not need global and international leadership, but nevertheless, what really makes the difference is the local approach. And so I put that there, think globally, act locally. You've heard this slogan for lots of different things in politics and otherwise, but it's definitely true for public health. And so we really need to make sure that we are acting locally with local partners, because ultimately, despite all of our support that we may bring from London or Geneva or Kyoto or wherever it may be, it's really the local partners that and the local population that decide how they're going to adapt behavior to try to, or if they're going to adapt behavior to try to limit the transmission of a pathogen. And so if we don't really succeed in getting that local population as a partner that's buying into this, recognizing the problem in the way that we might recognize the problem with our external expertise, then we will ultimately fail. And if we look at outbreaks, I think, although I do think our team and many others have contributed, ultimately it's the local population that gets a hold of these things. So that's extremely important. You may have seen these or read some of these sorts of books and seen the movies. If you see Dustin Hoffman, this is an older movie now, and this movie Outbreak, and very often what's portrayed here is exactly the opposite of people flying in and flying out and kind of saving the day. And that might make for a good movie, but it doesn't really make for the most important element of outbreak response. And so again, this isn't to say that international support is not important. I think it is. And that's what the group that I'm privileged to lead, we provide support, not only for the response itself, but also for for capacity development, and I'll talk about that. But at any rate, it's extremely important that we get beyond these sort of more grandiose ideas of, okay, it's mostly about getting the helicopter and having the team that flies in and save the day. That's maybe makes for a great movie, and but it doesn't really make for great outbreak control. So not the most important thing, flying in, parachuting in, and saving the day. And also the landscape in terms of outbreak response has changed rapidly. I've found over the time that I've been engaged in this field for perhaps the last 25 years or so. And so if we look, especially focusing on sub-Saharan Africa, if I go back, some of the early outbreaks that I was involved in sub-Saharan Africa, there really was very, very little infrastructure for outbreak response. Not only the technical infrastructure in terms of labs and things like that, but also just really having an organized program. And there was an assumption, and through that assumption, a dependency on people coming in that's, okay, WHO and Geneva, from Geneva, and US CDC from the United States, from Atlanta, and others would fly in and really kind of take over and run things. And that did happen for a while. And I think even, in my time for CDC years ago, that really was our approach. And we didn't really think of it at the time as a colonial type of attitude. We thought, and I think even when we came in, the expectation from our partners in Africa was often that, okay, we would sort of take over and run things, because after all, when you looked at an outbreak of Ebola, for example, how many people have experience with Ebola? Even those of you who are in your training in Kyoto or elsewhere, and certainly when I did my training, it's not the sort of thing that we spend a lot of time on. So there was that expectation and acceptance, but that has really changed over the years. And so we've seen, first of all, we've seen the emerging economies and technical expertise across Asia in particular, that really has much expertise that wasn't there if you looked at Southeast Asia 20 or 30 years ago. That's also happening in Latin America, and this is reflected in not only, of course, the technical expertise, but parallels the economic development of many countries across the world. But it's also happening, still a ways to go, but also happening in sub-Saharan Africa. And so now this idea that people would kind of come in and take over or be the leads is really something that is not considered appropriate. And so when we go to the Democratic Republic of the Congo, appropriately, the Congolese say, this is our country, we're in charge, we welcome the support, but we're the ones who are going to be in charge and organize this response. And so the national stakeholders are really demanding much greater control. And so that's a good thing, and that's something that we want to see. It's sometimes difficult for institutions and individuals who have been used to kind of coming in and saying this is what's going to happen, to now be in a more supportive role rather than a leadership role. But I think that's really the transition that we want to happen. There's sometimes a degree of mismatch, if you will, in terms of the desire for leadership, but the capacity to lead. And so in many, or not only to lead, but also the technical capacity. And so still in many areas of sub-Saharan Africa, there's an organization and a desire to be of national stakeholders to say, okay, this is our country and we're going to be in a leadership position, and completely appropriate, but the capacity to implement is still often quite thin. And so that can be challenging, because the groups that come in and say, okay, we do have the technical capacity in terms of helping with laboratory support and epidemiology and data analysis, they may have different ideas of how to do things. And so we do have a period of some tension, often speaking, quite frankly, between that local leadership and then the international stakeholders. But I anticipate that will resolve over time. And then, of course, this is really what we want if we're sincere about capacity development. It has to be that we don't take a leadership role coming in from London or Geneva or Atlanta or wherever it may be, that we really want that leadership role and that capacity development to come along with our partners. And so this concept of rapid deployments to kind of come in and fix things is really one that is not acceptable in any context these days. Again, not saying that the international support is not needed and welcomed, but it's still the leadership has to be on a local, national, and regional level. And if we look at how that has been traditionally set up, we have and these are sort of the traditional architecture of this. So international coordination has come from World Health Organization, based in Geneva, actually, where I'm speaking to you from today. And this is as you've seen with some of the outbreaks over the last decade or two, this has come into question, and there's a lot of criticism and pressure on WHO, some of it perhaps justified, much of it not justified. And but we've seen with the West Africa outbreak of Ebola a few years ago that there was lots of criticism that said WHO was too fast to call that out, or too slow, to call that outbreak and to really react to it. Somewhat ironically and related, I think the 2009 H1N1 influenza pandemic that started in Mexico and then into the United States and then around the world WHO was criticized because they were too fast to recognize that and say, okay, this pandemic has started. They were correct that the pandemic has started, but what no one could have known at the time, and we talked about it last week, is that it turned out to be not a particularly virulent virus that was circulating. And so there was frustration that WHO had said this pandemic has started and we really need to be paying lots of attention to this and putting resources into control, when ultimately, even though there were many, many cases, the case fatality was extremely low. But this is an extremely difficult position for anybody to be in, no matter how much expertise you have. Of course, when you need to say and sound the alarm, okay, something is important and needs global attention and therefore global or regional or national resources, for a few things it gets relatively easy. We never say, for example, that there's one case of Ebola. We would never say, well, let's not worry about one case of Ebola. Call us back when there's 5 or 10 or 100 cases of Ebola. Every case of Ebola is considered an outbreak. But for other things, it's much more difficult. And we have this challenge across the world for endemic diseases. And so if you look trying to figure out whether we're having just endemic spread, for example, of seasonal flu when we get into cold weather in temperate climates, and at one point do we say, well, this is the normal level of circulation, and now we have something that is considerably, significantly above normal, that takes different resources and a different approach. And so very difficult to say when you cross the line. Crossing the line by a little bit, relatively easy for Ebola in some ways, to say, okay, one case is an outbreak, but other things it gets much more difficult. And we see those challenges in diseases that are endemic, like yellow fever and others, where we know that there's going to be some degree of circulation. And when they cross a certain line, how far they are above that line to try to pull out other mechanisms of response. And so that's a challenging thing. WHO has also, of course, been challenged by a lot of international criticism that you've seen recently. We saw the United States up until recently, very recently, up until last week, withdrawing support for WHO. We anticipate that the election that happened and finally was called after days and days of people waiting to see how that was going to go. But the President-elect Biden has already stated that one of his first moves will be to restore funding for WHO. And this is not about really saying that WHO is doing a bad job or a good job. It's just a challenging job. And then as we go down from the headquarter level to Geneva, we have WHO regional offices. But we also have a lot of regional partners that have come up that are hopefully coordinating, but not formally within the WHO system. And so if we look, one of the partners with whom we work quite a bit is the Africa Centers for Disease Control, based in Addis Ababa and sponsored by the African Union, with support from other entities, from US CDC and Gates Foundation and quite a few others, Jack Ma in China. But this is an entity that's come online very recently, doing a fantastic job under John and Kengasong's leadership. And so we're really seeing some partners, but also some questions about, okay, if it's not all through the WHO system, how does it work out? Is it the African Regional Office at WHO that handles the surveillance, or is it Africa CDC that handles surveillance? To whom do we look really as the key partners? And then in what investments are made in those key partners, and how is it coordinated between them? And I think that can be done, but we're still seeing this changing, this evolving architecture and how that's going to work, I think. The good news in that is that there are just some building blocks, I think, some capacity that and things to work with. And sure, we need to figure out globally how it all fits together, but there is capacity and building blocks to put together. And then on that same theme, the national coordination, we're seeing there's a ways to go in many countries of the world. And but we're seeing especially some emerging national public health institutions like Nigeria CDC, for example, again under really a very capable leadership of Chikwe Ikweazu there, and really coming on strong and providing, expertise and local leadership and local capacity that we hadn't seen in a previous era. So there's much cause for optimism, really, if we look at these building blocks. It's not that every country has that degree of an NPHI or National Public Health Institute, but the idea, there are many that have strong NPHIs now or are coming along, and others that are working on it, and then also improving the capacity through Ministry of Health. So I think we're looking at a relatively optimistic scenario in that way. But we need to make sure that this flows really down, as I mentioned in my opening comments, onto a very local level. And so it really needs to get down to the local implementation and the community partners, and recognizing that even a national government may not necessarily be always the most obvious and welcome partner on a local level. So it can be challenging. We take that to a degree for granted in places, I presume, like Japan and the United States, although the United States was quite fractured, as we've seen, of the states that have not been united in their approach to COVID-19, and so many areas of the world. That can be even more troublesome and problematic in areas, especially in sub-Saharan Africa, where within what were ultimately very artificially created boundaries from a colonial era, you have incredible ethnic and linguistic diversity within a country in many places. And so you can imagine the challenge when, just on a logistical, practical level, if you have 20 or 30 different languages that are spoken across the country, and local health partners speak one language and people from national level speak a different language, those can be very challenging. We saw that and had a lot of challenges, ironically, when I used to work leading Lassa fever programs in West Africa, and trying to coordinate between Guinea, which is Francophone, and neighboring Liberia and Sierra Leone, which are Anglophone. And for the most part, most of the people in my experience in Liberia and Sierra Leone did not speak French, and most of the people in Guinea did not speak English. And then there were many, many different local languages that would be challenging to try to work between. And so there's still a long ways to go to make sure that this pyramid that you see there in green, that it broadens out at the base, that we really have this translating all the way down to the base, and not something that's top heavy coming from a Geneva or a London or Atlanta level, or even an Addis Ababa or Brazzaville level where Afro is located, but really translates down to the capacity to respond and detect and respond and prevent on a very local level. And so just, I think I showed this slide last week, but some of the things that I see changing is just the real optimism of some very strong, capable leaders in different places in Africa. And these are just three. There are many more. And we could put up such slides about very capable leaders in many other countries, in Singapore and Hong Kong and Peru and across the world, that I think in a way, realistically, that we wouldn't have been able to put up 20 years ago in terms of technical capacity, but also just the sophistication and understanding the big picture landscape of public health. And this has come through, in many ways, through what I would call the magic formula, but not the formula that we want to rely on. And so if you look at these leaders, they are all born and grew up in sub-Saharan Africa, but then came to the global north to train. Chikwe Ekwezu was at Public Health England for, I think, maybe 10 years or so. John and Kengasong at USCDC, both in Atlanta, and led the USCDC program in Cote d'Ivoire for many years. Shidi Moeti came and studied at the London School. Actually, at least two of these three have studied at the London School, and many others. And so really what you get is that combination of people who have, come and get the technical know-how and learn. And it's not only about the science, it's also about learning how the resources come into systems and how you develop hypotheses and implement programs and publish papers, and then use that to get more resources that come and support the work that you need to do. And then having gotten that experience, and then you go back to sub-Saharan Africa, in this case, with speaking the local language and understanding the local customs and how to navigate the political waters, that really makes for very, very strong leadership. But we can't depend on that, and because of course it's not really possible for creating that leadership pool with everyone coming to London or United States or Japan or wherever it may be. So that's certainly welcomed, but I think one of the things that we need to focus on is making sure that we are supporting the academic institutions in country, in low and middle income countries, and so that people with this expertise and know-how don't need to come away from or move away from Abuja or from Cameroon, where John and Kengasong is from, or wherever it may be, in order to get that sort of training and experience, and so that we have a rich pool of local leaders and through local training. And so that's one of the challenges still to be fronted, I think, in a global sense. So if we look at the systems, how they work, this is the Global Outbreak Alert and Response Network, or GORN, that is closely affiliated with WHO, and this has functioned since 2000. It's having its 20-year anniversary right now, and this has been an important element of putting expertise into the field. I've been working with GORN for many years and sit on the steering committee, and so I think GORN is doing great work, but it's also GORN and WHO, again, needing to look at the model and perhaps rejuvenating the idea of building the base rather than being too dependent on support that comes from outside experts. And we've seen that incidentally with COVID-19, because especially with all the fractured supply chain and fractured travel system, it's been incredibly difficult to get international expertise to the places where they need to be. And so fortunately, we've seen that, again, using the example of sub-Saharan Africa, but we could talk about many places in Southeast Asia or elsewhere, those countries have developed and stepped up in order to be less dependent, if you will, on some of the outside support. And so things are happening. And I'll give an example now and how we're approaching this in the UK. So the rest of my talk will be on the UK Public Health Rapid Support Team. And as I mentioned in my initial introduction, this is the team that I'm fortunate to be able to lead in the UK. And first of all, this is a relatively new entity. It came in the wake of the Ebola outbreak in West Africa. And you'll note that we intentionally called this the Rapid Support Team rather than the Rapid Response Team. The terminology that you usually see is Rapid Response Team. And the reason that we went away from that terminology is because, again, it seemed a little bit like we were flying in and flying out and saving the day. And we wanted to get away from that. And we wanted to underscore that what we're here to do is really to support local partners, local, national, and regional partners in terms of preventing and responding to outbreaks. We think an important part of that process, but nevertheless, we don't fly in and save the day. We're here to support others. And this came out of the West Africa outbreak. So during that outbreak, I was part of the time still based in Peru, actually, where I led a laboratory in Lima, Peru, but deploying very often to West Africa for this. And then also midway through the outbreak, actually switched and then was based at WHO. And but we saw that in West Africa with the Ebola outbreak, almost 30,000 cases. We covered this a little bit in last week's lecture, so go back and look at that if you'd like. But we saw really many of the shortcomings. And it wasn't just about responding to the outbreak, but it was recognizing that there were other things that we need to do in outbreak settings that are extremely important that we were not really set up to do, at least with the rapid approach that we needed. And so there was a health crisis for response, but it was a health crisis where in many settings, the only way to learn about emerging diseases is during the outbreak. And so if we have, for example, a therapeutic or a vaccine for Ebola, we can't plan a study and say, like we might be able to do for more common endemic diseases, We can't plan a study and say, okay, over the next 2 years in this particular place where there's good infrastructure and a team to implement a study at this university or wherever it may be, and we're going to test and see if this Ebola vaccine works or this Ebola treatment works. Obviously, we can only do that in many of these settings when there is an outbreak of considerable size. And so that it's really a challenging endeavor for us, where we need to not only respond to the outbreak, but also be able to put in place the research that needs to be done quite rapidly. And if you look, for example, at vaccine research, we usually consider, and prior to this outbreak, would consider that developing a product and getting a vaccine through to commercial market and availability is a multi-decade process probably, and millions of dollars. And we learned here that we needed to have the capacity to do that much more rapidly. And so when we conceived of the UK Public Health Rapid Support Team, or what we call for short the RST, we recognized that it wasn't just about the response, but these other elements of it were extremely important, that it had to have a research component, and it needed really kind of the broader approach that a government-funded entity may bring in terms of practical outbreak response, but it also needed really an academic approach. And so recognizing that, the way this was put together was a partnership of Public Health England. Public Health England is a government agency, and then the London School of Hygiene and Tropical Medicine. We also have involved various academic partners, University of Oxford and King's College, to name two. There are others that are engaged these days as this has moved forward. And this is funded by the UK government. It's funded through something that we call official development assistance. And the reason that I point that out is official development assistance is specific to low and middle income countries. And so we are not the group that responds primarily to what's happening in the UK when there's an outbreak, or in Europe. We're the group that responds really in low and middle income countries. And with funding for 5 years to start with, and you can see there the funding is due to run out in 2021, so in March, although we are up for refunding, where I don't think we will get cut, so we'll have to see in this extremely challenging environment of COVID-19 and the economic challenges, as well as the Brexit challenges in the UK, how that works. I think I'm not particularly worried. I'm not sure exactly how that's going to go, but we're still waiting for the government to work through all those challenges. But nevertheless, I think in being the primary entity of the UK for responding to outbreaks in the middle of a pandemic, I don't think we probably will get cut. So we'll see how that works as we go forward. And recognizing the challenges that I already discussed in West Africa, we have not only a mandate for response, but a mandate for research and capacity development. And so we try to put these things together as much as possible. So important to respond to the outbreak in the way that I like to describe it to a group that is, that you're a very sophisticated group of listeners, but for those who are less sophisticated, if the response to an outbreak is putting out the fire, then we like to and try to ask the question, well, what allowed this fire to start? What were the knowledge gaps that allowed this fire to start? And how can we work with local partners to put together the research and understand and fill those knowledge gaps? And then, of course, the capacity development is helping those partners with the capacity so that the fire doesn't restart. And so we work on all three aspects of this. It's a challenging endeavor. We need more resources, human resources, to do it. If I were to say to some of my colleagues, for example, at US CDC and other places, and say, well, we work on both the response, the research, and the capacity building, they might say, so what's the size of your staff? 300 or 400, and rather the size of our staff is around 35. And so we have an incredibly dedicated staff, and you can see here that the different skill sets in terms of epidemiologists, laboratory microbiologists, social scientists, clinical researchers, infection prevention and control, data science, field logistics, training, and many other things that come along with this. And I should mention that we are not the primary group for just clinical support. And so there's something called the UK Emergency Medical Team. And so if you need a group of doctors that will come and set bones that are broken because of an earthquake or something like that, that's a different entity. We coordinate with them very closely, and we often deploy with them if there's need for both their clinical support and our broader public health support. We have, in addition to the people that I mentioned of our full team of 35, and that 35 includes quite a few, not all of them are what we call our core deployable team. Many of them are also, as you can imagine, there takes a considerable administrative and support staff and operations staff to really put these people into the field and make sure that they have the support and working with our local partners. In addition to our core team, we rely on the field epidemiology training program in the UK, and also have a reservist cadre. And so these are people that we can pull in. It's not their full-time job to work with us, but they get pulled in for various reasons. First of all, of course, surge capacity when we need more people for an outbreak that's particularly large or complicated. And then for particular expertise that we may not need all the time, but for example, expertise in arthropod-borne viruses. Most of the outbreaks to which we've responded to in our brief history have not been arthropod-borne viruses, but of course we've seen historically things like Zika and dengue can call for international support, and so you need that expertise. And so the reservists can bring that expertise that we don't have full-time. These are people who are all trained and pre-accredited to rapidly deploy. And it allows us to engage really the broad capacity across the UK in academia and the private sector. And so we work out with them a whole system to be able to call on them when we need them. I should note, and often I'll get people who say, oh, I want to join that team so you can call on me when you have something, but it's not quite that simple. There really is quite an investment that we make in the people for our team, and they need to make. And so it's not sort of just sending, paying for someone's travel to put them into the field somewhere. There's considerable specialist training and pre-deployment training and safety training. Much of this is online, but also we put everyone through a 5-day field course, Safe and Safe Plus training done in the UK. This is not training to deal with epidemiology. It's the settings, unfortunately, where we often work, where there are considerable safety issues, and what happens if someone gets taken hostage, or if you are driving somewhere and gunmen come out and stop your vehicle, and how do you deal with these sorts of situations? And I'd like to say that has never happened to myself or our team, but in fact it has happened. And so we've had in various places over the years, things do happen. And I think I covered this a little bit last week and told a few stories of some intense moments. So it does require someone who's ready to work in these sorts of environments and understand also the local and international architecture of working there. We don't go in as independent entities, we go in as part of a team, and then there's considerable elements of medical clearance. And so since all this has to happen relatively rapidly, all this needs to be done in advance. And so everyone who works for our team who is deployable needs to have medical clearance. That means they need to have appointments to make sure that they don't have any medical problems that would preclude them or prevent them from deploying, have all their vaccines up to date. We're ready to give them malaria prophylaxis if needed, depending on the country that they go to. And so it's a considerable investment to put this together. It's not something where you just say, okay, and I do get these, and I appreciate the spirit, but I'll have people who write me and say, I hear there's an outbreak here, can you send me to this place or that place? And the answer is no, because it really takes considerable effort and investment to have people ready to go. And this is just an example of the sorts of training that people go through. These are not military doctors or anything, but nevertheless, they go through this training and learning how to deal with these sorts of settings. And again, I would like to say that our teams in the field have never had to put on helmets and flak jackets, but unfortunately, especially for the Ebola outbreak in Eastern DRC, and I talked about this last week, that's not true, and they have had to put on helmets and flak jackets and assure their protection. So this sort of training is extremely important. How do we deploy? And I get this question a lot of, how do we decide where we go? And really the easy answer is you can only go in the world where someone invites you to go. It's, it's like if someone says, where do you have dinner? Which friend's house do you have dinner? You have dinner at the friend that invites you over for dinner. And if they don't invite you over for dinner, it's not an option, really, even if you think it should be. So even if we think, okay, the outbreak of whatever disease it may be in a given country really is getting out of control and needs support, and we think we have support that we can offer. Each nation is sovereign, and so, of course, really, unless they recognize that need and say, we would like you to provide support, it's not possible for us to come in. We can ask, we can contact people through diplomatic channels and say, just so you know, we have support that is available if you would like. And then sometimes the support will come through a bilateral request. So, for example, we've supported Nigeria CDC for Lassa fever outbreaks on numerous occasions when Chikwe Ikwezu that I mentioned earlier from Nigeria CDC, basically calls me up and say we need support and how can we work that out, and so we put that together and provide that support. The support or the request can also come through WHO or GORN, as I mentioned earlier. So a country, rather than coming directly to us, can go to GORN and WHO and say, we need support for a given event, and so we need epidemiologists or laboratory scientists or whatever it may be, and can you put out a call for support? And so then GORN will do that, putting out a call to GORN partners who can help out, and we often respond to that through GORN and then deploy through them and with WHO. And then often, or on occasion, I mentioned UK emergency medical teams, and so when those teams deploy, we also can deploy to provide epi or laboratory or logistic or IPC support with them. So it really just depends, and the importance, I think, is, first of all, having a team that is well-trained, well-prepared, and ready to go very rapidly. It's not a job that if you're someone who doesn't like to have changes in your life, it's not a job to have, because all the contracts for everyone on our team stipulates that they need to be ready to deploy within 48 hours notice. That doesn't mean that they don't get leave where they're off, but if they're not off, if they're on, then we say, okay, this is happening, so they need to be able to respond appropriately. And they do spend many across a given year, many weeks and months traveling and internationally. COVID-19 has limited that some. It's not only the international time spent, of course, for the outbreak response, but this is also the team that is working in various research and capacity development projects overseas. And so you might be in Nigeria working with Nigeria CDC for a month on a research project that we do in collaboration with them, and then come home and be home for a few weeks and then say, okay, now there's an outbreak of cholera in Ethiopia, for which we've had a request, and try to put teams back in the field. So it's a challenging and rewarding job. I think we have an incredibly dedicated team. And this is just an example. It needs to be updated. I think there's a few more, but you can get an idea over the course of our little over 4 years of existence so far, the places where we have deployed, in some countries more than once, and the sorts of things we've deployed for. So cholera or acute watery diarrhea in Ethiopia, COVID-19 in quite a few different countries. Ebola in the DRC, very engaged in the Ebola outbreaks in DRC over the last some 2 or 3 years, really, both in terms of the outbreak response and also research. One example, I'm the co-PI on the study of the J&J Ebola vaccine that we've been doing in Eastern Democratic Republic of the Congo for the last few years. So a lot of things going on that you can get an idea here. I think some of the places that are not yet colored in on this map, we have teams in the Gambia right now, also a small team, or at least one person in Bangladesh, working on a seroepidemiology study for COVID-19 in Cox's Bazar in the area where the displaced Rohingya population that came from Myanmar. So those sorts of things. So this is just an example of one of our deployments, a little bit of an unusual one here, where we were requested from the government of Sierra Leone to deploy a few years ago after there were very heavy rains that created landslides and large numbers of internally displaced people. You can see on the lower slide there, that ruined house, and all that area that is all dirt and water previously was all inhabited in homes. And so a whole big section of a degraded hillside basically came down with these heavy rains. And so we had large populations, internally displaced people in unhygienic settings. And so the recognition that waterborne diseases like cholera and dengue, this was a very vulnerable population. And so our team was requested and went in to help shore up the epidemiology and the surveillance for waterborne diseases and also the laboratory diagnostics. I don't claim that it was because of our work, but whether we did a good job or whether we were fortunate, there were no outbreaks of cholera or typhoid. I mean, there were isolated cases of many diseases, but there were no large outbreaks in the population. So just one example, this was a little bit more preemptive than response to a given pathogen. I won't have time to go over all the details of our research or capacity development program, but so our research program is around 5 main themes that you can see here. And although this is by no means exhaustive or completely limiting, so we have things outside these elements as well. And then we have probably somewhere over 25, I think it's probably close to 30 different research protocols that have been implemented over the 4 years so far. Probably 5 or 6 ongoing research programs right now, and others that have come to completion, are either published or reports out there, or are still, those reports and publications are still in process. So a very active and diverse research program. And then getting to the capacity development side of things, and I think I may have mentioned this last week, but I like to quote James Bryce, a British statesman, who said, "Medicine was the only profession that labors incessantly to destroy the reason for its existence." And this is really our ultimate philosophy in the work that we do. And so that what we, not necessarily medicine, but we want to work so that years from now, people would say, why would anyone in Nigeria or the Congo or Bangladesh or wherever it may be need anyone to come from London or Geneva or Atlanta? Why don't, they have the capacity to do it themselves. And so we initially go through a period where outbreaks are detected very early and the response is organized and the technical expertise and logistics are in place. And so there really is not much need for that coming from London or elsewhere. And ultimately translating that to health system strengthening so that our outbreaks don't occur at all, of course. And this is very idealistic, but I think it's really what we need to work towards. And ultimately, I'm not worried about being out of a job anytime soon. I think this is not something that will happen right away, but nevertheless, this really has to be what all of us work for. And I'll give just an example of kind of the tripartite remit of our team and some of our work regarding a disease called Lassa fever. If you're less familiar with this, this is a disease that is endemic in West Africa, first discovered in 1969 in Nigeria, and then seen in quite a few countries with sometimes endemic but epidemic spread in especially in Nigeria, Sierra Leone, Liberia, various places. It's a rodent-borne virus that is spread by a common rodent commonly called the multimammate rat. The scientific or species name is Mastomys natalensis. And so we see this across West Africa and a disease that I've worked in for a long time. Even prior to my present job as the director of the RST. But if you look at kind of our activities with this over the last few years, so we've been involved in outbreak response, and as I mentioned, providing different types of support for Nigeria CDC at their requests in 2 very busy Lassa seasons, and really where there was endemic that was leading towards epidemic spread in Nigeria over the last few years. This is a seasonal disease, and you see much more of it typically in the dry season. And so we provided epidemiologic, laboratory, logistical, and other support for fighting the epidemic, but also very engaged in research. And so we have projects on the clinical evolution and the pathogenesis of Lassa fever, which is not well understood. There's a drug called ribavirin, really in the whether that drug is really working well and the pharmacokinetics of that drug are, again, not well understood. And we have studies looking at that. On the epi and lab side, developing an assay. There are not good assays for this, and so developing an IgG oral fluid assay that would allow us to better understand the epidemiology and the distribution of disease. Testing of loss of negative samples and all sorts of outbreaks. One of the things that happens is it's relatively easy to fit the case definition for Lassa or Ebola or things like that. So if you put a case definition that you want to be very sensitive to identify all the possible cases. So it may be fever, headache, nausea, and vomiting. And if you're listening and say, well, fever, headache, nausea, and vomiting, I've had all those things in the past. If I had Lassa fever, if I had Ebola, and of course, probably not. But in these settings, some people will have those things, but many people will have of course, not the target disease during the outbreak. And so understanding better what are the other things that are happening and how do we ensure that the person who has dengue fever during an outbreak of Lassa fever or during an outbreak of Ebola is also getting diagnosed and the care that they need. We've worked very diligently on many of the social science aspects of Lassa fever and looking at healthcare seeking behavior for febrile illness. In Sierra Leone, for example, we've seen that in recent years there have been in what was considered the epidemic area for Lassa transmission. We've seen very few cases in recent years, and we think that may have been related to the large Ebola outbreak that happened there. That really was a miserable, difficult situation where there was a lot of nosocomial transmission and transmission in the hospital, and that may have scared people off of coming to the hospital when they have now Lassa fever, even though, of course, the Ebola outbreak is over. So looking at healthcare seeking behavior, and then capacity building, development of a clinical research capacity at a place in eastern Sierra Leone. This has been a little bit challenging to continue on with because, as I mentioned, in order to do that clinical research, you need people presenting to the hospital and with Lassa fever, and that has not happened very commonly lately. So a challenge there to continue that, but we're doing our best. And then providing a lot of technical insights to a group that you may be familiar with, Coalition for Epidemic, actually is mistermed there. It should be Coalition for Epidemic Preparedness Innovations, or CEPI, a group that we work with that is leading many vaccination efforts, including vaccination efforts for COVID-19, but also for Lassa. And it's not just about developing the vaccines, it's also about understanding how you use the vaccines, what's the target population, and so we're working a lot to provide the epi data and working with CEPI, both on the level of a high level in terms of on technical advisory committees, but also with projects on the ground in Nigeria and Liberia. So you can see there, although there's much work to be done, we're doing our best there to cut across really the response, the research, and the capacity building. And that's really how we view the value of our team. This is just, we didn't create this center. This was created actually through previous projects that myself and many others have worked on over the years. But this is a new Lassa fever ward in Kenema Government Hospital in Eastern Sierra Leone, which we think has great potential for a clinical research center for not only Lassa, but other diseases. And I just thought I would give a few words here as we wrap up about our work on COVID-19. This slide needs to be updated, but nevertheless, you can get an idea. So our team has been very active on COVID-19. Like everyone in the world, our travel has been relatively limited. So many deployments that used to be in person are now done remotely, although we are seeing in recent months, we've still have been managed to deploy individuals to Bangladesh and the Gambia and Tajikistan and a few other places. But so we're learning that what can be done remotely, and extremely important. And I think what we'll be seeing in the future is more of a hybrid level support. That it's important, of course, to develop that remote capacity, because no matter what, no group, certainly not ours, but no group really has the capacity to deploy rapidly someone to every corner of the world. And so having that remote support and things, we're seeing so much material that can be available online and automatically, instantly available for people that need it. And of course, the internet connection is developing across the world. And so very few places the connection may not be the most stable, but very few places that are completely disconnected right now. And so we're seeing both the promise and the limitations of that remote support. And I think going forward, when we all hope that the world, I won't say normalizes, because I think we're a long way away from going back to a previous normal, if you will, and I'm not sure we want to go back exactly to that normal for many reasons. But when it stabilizes, at least, I think we need to be looking at drawing out the best of both the remote and in-person support. Other activities, just to mention a few of our team, we put together a massive open online course, or MOOC, on COVID-19 that was through the London School, had over 200,000 registrants for the course. And the initial version was in English, but that was ultimately translated to, I think, 5 or 6 different languages: French, Spanish, Portuguese, can't remember, Chinese, and a few others. And then have been working in various research projects with a lot of different collaborators with Africa CDC and others. So lots of things going on, really. I think I showed this slide last week. If we look at the future of the RST and the future of outbreak response, one of the challenges that we still have, again, is that the biomedical, social, and political determinants, we can't look at these as separate entities. They are all intertwined, and we need to be collectively active. We're all here working in the health sciences, and so we would think that the biomedical part of that is where our expertise is and our component. And I agree that it of course is, but nevertheless, if we ignore the social and political elements of that, then we are really are not going to get to the bottom of things. And if you looked back at the slide where I mentioned our various deployments, you can see that quite a few of those diseases for which we deployed and offered support were vaccine preventable illnesses. And so that really is an example that it's not all about the technology. We have the tools really to prevent those diseases. They've just not trickled down to the people that are most in need. And so where do we see, after the first 4 and going on 5 years of the RST, where do we want to go with this program? We envision expanding our expertise and breadth across the UK, but also especially overseas with partners, and I've just named a few here: Nigeria CDC and Africa CDC, and increasingly that we will draw in resources, technical expertise for the UK, but nevertheless, the nature of our response will be shaped in conjunction with those partners in low and middle income countries. And so it's not so much about what research project we decide to do, it's identifying, and I'm not saying we don't do this already, but even more, I think, identifying what do people in Nigeria CDC or Africa CDC or ministries of health in different countries, where do they say these are the important gaps in knowledge that we need to approach, and how can you assist us, and how can we do that together? And then diminishing the siloing of outbreak response. I put up that slide about cholera in Yemen, and there's really traditionally been somewhat of a siloing. If what I mean by that is a parallel approach, and so you have humanitarian organizations that come in and respond and kind of provide care, and then you have technical organizations that provide outbreak response, and we don't always have an integrated approach to that. And so that's very challenging in many ways. It's challenging because, of course, it doesn't work very well when we go, understandably, we go to North Kivu, where the Ebola outbreak persisted for a few years, and we say, here's the way that you need to change your behavior, and here are the things that you need to do to protect yourself from Ebola. And people who have never heard of Ebola are asking, well, what about the support for malaria and typhoid fever and all the things that my family and I have been suffering from over the years? And so, not because we're doing it on purpose or because we're not feeling people, but what it amounts to at times is that we're walking by the child dying of malaria to find the child dying of Ebola. And ethically, of course, that doesn't sound like it's the right thing to be doing, but also strategically, it's not the right thing to be doing. Because again, coming back to that need for local partnership and local buy-in, unless unless a mother or father is convinced that you are there really to help their child, whatever that child may have. And it's not easy, of course, and we can't do everything, but unless we have an approach that is strategically looking at broadly all the things that people are suffering from, rather than one particular disease that may not be the one that they recognize as the biggest challenge in their community, then strategically we will have a difficult battle. Just a few last slides. One of the things that from the London School, putting on my London School hat, that we are working on is creating a new Center for Epidemic Preparedness and Response. The point of this is not to develop new teams to fly into the field or anything, but really to understand, and we've seen this for COVID-19, that of course we need epidemiologists and physicians and data scientists, but we're understanding that we really need to have a very coordinated response that includes certainly social scientists, but also health economists and political scientists. And if we've seen anything from the COVID-19 challenge, we've seen that a very fractured response where one group may be taking into account the more classic elements of transmission of a pathogen, but not taking into account the economic or mental health impacts of a given mitigation measure, then we really don't solve the problem. And so we really need to work together. And so this is an entity to kind of have cross-cutting support across many different disciplines that we're fortunate to have at the London School, but also with many partners around the world. We really view the London School these days as kind of a global hub, but for an international operation and international activities. And in fact, more people who work for the London School who are not based in London than are based in London these days. And so I think that's really what we need to foresee, both for this center, but also for the global architecture of outbreak response. So I'll end with the same sort of advertisements that I put up last time. Certainly welcome you to our annual meeting. Normally this would be in person in Toronto, but the American Society of Tropical Medicine and Hygiene, I'm biased because I play different roles as the scientific program chair and actually the president-elect of this society, but a great place to really learn about tropical medicine and outbreak response, and really the expertise is incredibly rich here, so please join us for that. One of the advantages, if you will, of not having an in-person meeting is it's all available online, and with registration is all recorded as well, so you don't have to watch it or participate in it all at once if you don't have time. I mentioned a much smaller operation, Doctors for Global Health, an NGO that works on health and human rights that I would encourage you to check out. This is something that I was privileged to start years ago with various colleagues. And then if you're interested in more on the Rapid Support Team, a few places, you can check out our websites. We do have an interest group and journal club that meets periodically, including meeting now remotely. And so you don't have to be in London to be on this listserv and participate with us. So feel free to email William Nicholas at that email address if you'd like to be on that listserv and keep up with our activities. So I think that's my last slide. Yeah, some supplementary reading there if you're interested. Same slide from last week. And happy, Ayako, to answer any questions. Thanks very much.
Thank you so much, Professor Bausch. Such a wonderful lecture that we have learned so much, and the difficulty and challenges of deploying experts in a developing country in time of rapidly needing the support for preventing infectious disease. So now, any question from the participants?
Hello, hi there.
Hello.
I just want to say thank you very much, Professor. That was a really interesting talk, and thank you so much to Kyoto University for hosting the event. I am currently a student at LSHTM. I'm doing the MSc Control of Infectious Diseases, and I'm very interested in your work, Professor, and I wondered whether you ever host summer projects for MSc students, and whether that would be something I could email you about.
Indeed, we do, and please do email me. I won't say we have a list all worked out, and so it's a process, and perhaps even a more challenging process right now. Obviously, we all recognize that COVID-19 is making things more challenging, but I certainly encourage student engagement with us, and happy to explore that with you. So yeah, why don't you send me an email, and we'll see what we can. We'll set up a time to discuss.
Fantastic. Thank you so much.
Yeah, you're welcome.
Yeah, another question?
Hi, thank you so much for such an interesting presentation. I'm wondering, as we move forward with capacity building in low and middle income countries, how do you see the role of WHO and other large international organizations changing?
Yeah, I think that's the big question. Thanks for offering that. And I think, if you paid attention to this, you've seen just a very challenging time for WHO, especially in the last, 5 or 10 years. I mentioned that WHO was criticized for acting too rapidly for H1N1 in 2009, criticized for acting too slowly for Ebola in 2013 and 14. I'm not a person really who, I don't have a knee-jerk reaction to defend nor criticize WHO. I worked at WHO for 3 years here in Geneva, and also have still work on various committees and have collaborated with WHO for many years. I think that we do need to, WHO and others, really rejuvenate our efforts to make sure that the support that we're providing is really coming from a local and regional level. And like I said, there are local and regional and national building blocks to work with, I think, that were not as developed in a previous era. So, and it does take a little bit of, it's challenging to people because it takes giving up a little bit of control, right? And saying, well, yeah, I'm not going to be at the center of this, and someone else is going to be at the center of it. And so I think that's a little bit challenging for all of us. If we don't do that, what we will see is that international organizations will ultimately get left behind, because I think that we're seeing that that the expectation is that there will be a national and regional approach to this, and that the leadership will be from those areas. There are also funding as part of this, and so if you don't have a global approach, and we see this from London School or anywhere else, if you're not really contributing on a global level and contributing to that capacity development, people start asking the question, well, why would I, provide resources to London School or to the Rapid Support Team? Why don't I just give resources to Nigeria CDC or to Africa CDC? And that may eventually be the right thing to do. But right now, I think even colleagues at Africa CDC and Nigeria CDC, as examples that I use, would say, yeah, we want the support, we want the engagement. And I don't think we need to be afraid of that, overall. So we see, although there's, I'll say, a healthy competition. We don't say, well, there's already a university in the UK, right? So we don't need another university, or there's already people who do research, so we don't need other people who do research. I think there's, a global need and global efforts, but we do need to, I think, from the WHO level, we need to push that out and really rejuvenate our efforts to have that local sponsorship and local engagement. And we're also seeing how it's not only about WHO, but it's about many other elements of the biomedical infrastructure and response system. So I mentioned this, I think, last week. I don't think the London School people we had a glitch in the communications, and I don't think anyone at London School knew about this last week. You can go back and find the recording. But if we look, for example, at local production of 52 countries in sub-Saharan Africa and local production of vaccines, there are 2, perhaps 3, but very, very few countries in all of those 52 that actually themselves produce vaccines. So South Africa produces vaccines, Senegal produces vaccines, and a very small supply traditionally of yellow fever vaccine that really came out of, historically, the Institut Pasteur de Dakar in Senegal. And So, if we look at really, it's not only about kind of providing the personnel, but it's also really those other things that are extremely important. And so John and Kengasong and others are, recognizing the long-term approach is not just about where the people come from, but that production of vaccines and therapeutics and, needs to be somewhat more homogeneously spread than it is right now. That's very, very clustered in resource-rich countries of the world. So I think we're on the right path, but we still have a long ways to go. Thank you
so much.
Any other questions or comments to Professor Bausch? What you thought about after participating in this seminar?
Professor, thank you for the lecture. It was very informative. This question is from the last seminar I wanted to ask you, but the time was up, so I will ask you today. So last time you mentioned that this COVID-19 has no underlying immunity. So this means that this is not a natural virus?
It's not a what virus?
Natural, like it is not by nature.
So what we know from other coronaviruses. So first of all, the family of Coronaviridae, if you will, using the taxonomic term, is a family that prior to not this outbreak, but to the 2003 SARS-CoV-1 outbreak in Southeast Asia that started in southern China. So prior to that, the coronaviruses that we knew, there wasn't much known. We knew various coronaviruses that were primarily animal pathogens that infected turkeys and chickens and pigs and a few other things, a few other animals, usually not with severe disease in animals, and a few known coronaviruses that infect humans and cause mild respiratory or mild gastroenteric disease. And so when SARS came in 2003, and ultimately that coronavirus, SARS-CoV-1, was identified. That, and if you look at a phylogram in terms of genetic sequence, it's completely separate from all those others that cause mild disease. Those other ones that cause mild disease, it's fairly well recognized that there is reinfection. So infection, the first infection of those diseases or those other non-SARS coronaviruses, there is reinfection and disease that can be caused. And so that's what we know coming into this. And then we had SARS-CoV-1 in 2003. SARS-CoV-1 was also, the evidence points to, introduced to humans through bats as the primary reservoir, perhaps through an intermediate animal reservoir. We can't know. A very similar story, if you will, than what we're seeing with COVID-19. Although the virus is somewhat different, but nevertheless, those two SARS-CoV-1 and 2 viruses, they cluster completely separately from all the other coronaviruses that we know. And so what we know coming into it was the other coronaviruses, there's reinfection. SARS-CoV-1, we were ultimately quite successful in, it was challenging, but successful in stopping that outbreak. And we don't believe that virus is circulating in humans anymore. We haven't seen any with once the outbreak that was controlled. There were a few laboratory infections that occurred after that, which were rapidly controlled without onward transmission. And so now that virus has not been seen in the world since 2004. And so we have no evidence whether there's reinfection with that virus or not, because it's not circulating in the wild. So those are the things that we have to go on so far, are the other coronaviruses, which are quite different genetically, and then SARS-CoV-1, which is somewhat similar genetically, but is not circulating in the wild and in humans as far as we can tell right now. So then we look, what do we know from those diseases? We've had, and from COVID-19, we've had a few reported cases of reinfections, very, very few, and it's really always hard to make conclusions from those very few cases. They may well be right, but one always has to consider that there can be laboratory error and lots of different things going on, and that's not a a fault of any investigator, but just these things happen, and they may be atypical. And then we look at what we know in terms of protection from the COVID-19 infections that we have so far. We see in many, but not all studies, evidence of waning antibody after months of infection. We've seen recently some infection of not waning, but maintained cell-mediated immunity. And antibody is, I think we talked about this last time, antibody is not the only thing that's important to measure. So you can have waning antibody, but still have cell-mediated immunity that is harder to measure, can be measured, but harder to measure. So I think we're still really up in the air about reinfection. One would anticipate that initial infection will provide protection for some time, whether that's 3, 6 months, 12 months, 2 years, we can't really say. And of course, we haven't even gotten a year into this COVID-19 outbreak. So even if we could go back and test all the first people who were infected, we still wouldn't know, they're still not a year past their initial infection. And then it's probably reasonable to suspect that secondary infections would perhaps be less severe than primary infections. So I don't think it's, I think it's something that we really don't know the answer to yet, and how important it will be. As we discussed last week, the vaccines and reaching herd immunity through vaccination is one approach, but I think at least for the time being, it's not really a panacea. It's not something that's going to make everything right again or perfect again. We're going to have to really learn to deal with this virus in the ways that we do have evidence in terms of physical distancing and consistent mask wearing and hygiene, hand hygiene, that can control the virus, but we need to do a much better job at it. And then additional very valuable tools that we hope will come online will, of course, be a vaccine if we can get to that. And as we discussed last week, an effective and widely available and easy to give therapeutic would be a game changer if we were able to say, well, if you did get COVID-19, don't worry too much about it because we have a good therapy and so you won't die from it. So, but we're still a ways away from those tools, not only in terms of scientifically the development of them, but also the challenges of production and distribution and equitable distribution around the globe. So we need to come back right now and be focusing on those important elements, that the stuff that's not the exciting things and what should be the simple things, but apparently are harder for us to really act on in terms of masks and hand hygiene and physical distancing. And if we can do that, we can also, I know this is a long answer to your question, but if we can do that, we can get back to, some version of normal. It won't be normal, but we can get back to saying, okay, we can keep shops and restaurants and things open in a different way, but and we can keep our economy moving, certainly not in the way that it was before. So that really needs to be our short-term goal.
Okay, thank you, Professor. Thank you.
I also want to ask one question. So in today's lecture, you explained to us about the UK Rapid Support Team. And I think it's a very unique and amazing team that you have developed. You explained to us that not only deploying people in case of emergency, but you also do research and also capacity building. But how did you come up with this structure of the program, and also what's the view of British government in supporting, maintaining this project?
Yeah. So the first question, how this was conceived, again, a little bit as I discussed with Ebola, recognizing that it wasn't only about the response, but recognizing that the research element, that these are our only opportunities often to do research. And that is challenging to do. And we've recognized that prior to the existence of the Rapid Support Team, but one of the challenges has always been that you say, okay, well, we don't have enough resources. We have to focus now on stopping transmission and stopping the outbreak. And so then when all that's over, maybe we can think about research. And that, while that makes sense, of course, what happens is when all of it's over, it's too late to do the research, and you can't do the research because there's no more patients to enroll in a clinical trial and those sorts of things. And so one of the ways to get around that, we recognize that you need to have the resources to not have the research taking away from the response. And one of the ways that you need to do that is if you rely on teams that are just put together in an ad hoc way. And so somebody who works for the government or works for a university, and you say, okay, we're going to pull you in when we need you, gets very difficult because they have their full-time job and other things to do. And so you really don't have resources. You can maybe pull them in, but you don't have the resources to pull them in to do the outbreak response, but also to work on the research. And so we put together this program designed to really have people that work full-time for the rapid support team. They don't have other jobs. I mean, we do have the reservists, of course, but our core deployable team, this is what they do. We don't have to take them away from anything. So that does take resources. It's important to commit the resources. And then we come to your second question: what does the government think of us, and what can we anticipate moving forward? From all the feedback that I get from ministers and from the Parliament level in the UK, I think, and from the Chief Medical Officer Chris Whitty and Sally Davies before him, and certainly from the London School, I think we're well thought of as an important element in the UK and the response, and recognizing that it's not only, as I've mentioned today, and I think last time, that it's even if you don't think that it's particularly important to respond to outbreaks in low and middle income countries, it's also important that that's how you prevent the outbreak from coming home to the UK and affecting the local population. So for both reasons, it's extremely important. So I think, in terms of how our team is viewed, quite positively. Of course, I'm biased because I've been privileged to set it up and direct it. But then there's the reality that I can't know, and none of us can know. The UK, if you follow the news, is one of the countries, of course, that has really very rapid COVID-19 transmission right now, and is unfortunately in a position to have a major economic impact of COVID-19. And so we'll just have to see. I don't think I'd be highly surprised, and from the information I get from the Department of Health and Social Care and higher levels in the government, I don't think our team is going to get cut. What degree of funding we'll get. There's, quite frankly speaking, also just the political part of this, and you can imagine sort of this isn't the reason to do things, but the story in the daily news of cutting the team that works on pandemics in the middle of a pandemic wouldn't look very good, right? We can all understand that. But I don't think that's the reason that we will continue to exist and continue to be funded. I think it's because we recognize that this is an important work that needs to be done.
Thank you so much. Yeah, I hope that your activity will continue. And I was also wanted to say that other countries should follow your model of creating such a great team. Yeah, thank you. We actually do have various other countries that have now and prior to COVID-19 that have contacted us and been interested in come to meet with me in London and saying, how would we put this together? And there's no one size fits all. I don't say that our model is perfect and everyone should do exactly as we do. And we're learning how to adapt and change as we move forward as well. But nevertheless, yeah, there is quite a bit of interest actually from other countries and how to also adopt similar strategies. Thank you so much. Yes. So any other questions? This is last question. Yes, please.
Do we have time? This is probably something that was covered in the last session, which I'm sorry I didn't know about, but I was just interested quickly to hear about your thoughts on the impact of COVID-19 going forward on the response to the hemorrhagic fevers in low-income countries. Has there been a massive redistribution of resources? Are these outbreaks going to become more neglected as a result of COVID-19?
Well, it's not only a question of responding to other outbreaks. It's equally and probably more importantly, or equally importantly, a question of responding to other endemic diseases, including non-communicable diseases that, as we know, are a major cause of mortality and morbidity in low and middle income countries as well. So we are seeing challenges, and it's of diverted resources where we say, okay, now everybody needs to be working on COVID-19, but and not only say, for example, is there enough capacity to respond to the ongoing, but hopefully almost over Ebola outbreak in the other side of the Democratic Republic of the Congo in Equateur province, which is probably somewhere around a week away from being able to declare that outbreak over if we have no new cases. But we were not able to provide as much support for that as we normally would. Fortunately, there were very experienced Congolese investigators who could respond to it in an area where there'd been outbreaks before, and also fortunately in a way in a very isolated area, so there wasn't a lot of contact and ability for that virus to move between areas and spread. But even, equally importantly is just, can we get the routine vaccinations into people to make sure that we don't have resurgence of, which we're seeing around the world for other reasons, and vaccine resistance and as well. But do we have resurgence of measles and other things? Do we have peaks of malaria, morbidity and mortality, and HIV care and things like that. And so unfortunately we have seen, and one of the things that we struggle with for COVID-19 and prior to COVID-19, if you looked at the large Ebola outbreak in West Africa, there were peaks in almost all the other non-target, if you will, diseases and lapses that occurred in people not getting, for example, their TB therapy or their HIV therapy. And so a very, very challenging environment. And so we're trying to, recognize that, do a better job of recognizing that these days, but it's challenging and also challenging just also in the logistics of fractured supply chains and just, flights to get products into countries. But I think I won't say that it doesn't continue to be a huge problem, but there's more than there had been in future or in past years, a recognition that we need to really keep our eye on that ball as well and not let everything drop to the ground. But limited resources, and then also challenged by, of course, the many logistical impediments.
Thank you so much, Professor Bausch. We wanted to listen more about your stories, but the time is past, so we would like to end this short course. But at the last, can everyone open your face and thank Professor Bausch?
Thank you very much.
Great, thank you all of you for joining today, and pleasure to speak with you. Good luck in your studies and careers. I'm sure I'll be in contact with some of you.
Thank you so much. We learned a lot from your lecture today, and hopefully we will be able to see you again for future collaboration.
Hope so. Bye-bye.